To this dental news project that I will do today, and I wish that you all understand and listen and hear this dental project. I will write dental news, and I hope you will enjoy this educational project. Now let's look for dental diseases that we can understand and read about online. Here we have a PDF article that we can read. But I cannot access. Let's try another one. This one we also cannot access. Hopefully this one we will be able to. This one we can access. I will read to you what is this all about. Increased risk for COVID-19 in patients with vitamin D deficiency. Highlights. Vitamin D deficiency is strongly associated with increased risk for coronavirus disease 2019 COVID-19. The odds ratio for COVID increases with vitamin deficiency in black individuals. Diabetes, obesity, and periodontal diseases are associated with an increased risk for both COVID-19 and vitamin D deficiency. Abstract. The 2019 coronavirus disease pandemic has disproportionately affected a variety of patients with underlying risk factors such as respiratory and cardiovascular diseases, diabetes, obesity, and the black race. Vitamin D deficiency, which can result in a compromised immune response, has also linked to increased risk and increased morbidities associated with COVID-19. In the absence of large-scale longitudinal studies to determine the strength of association between vitamin deficiency and COVID-19, cross-sectional studies of large patient cohorts can be used. Methods. We used the I2B2 Patients Registry platform at the University of Florida Health Center to generate a count of patients using the International Classification of Diseases. Diagnosis codes for the periodontal through the June, etc. Results. Patients with vitamin D deficiency were 4.6 times more likely to be positive for COVID-19, indicated by the ICD, than patients with no deficiencies. The association decreased slightly after adjusting for sex. Odds and malabsorption also associated decreased significantly but remained robust. Let's read about the conclusion. Vitamin deficiency is significantly associated with increased risk for COVID-19. Introduction. Vitamin D is not a vitamin in the traditional sense. Rather, it is a group of fat-soluble compounds responsible for intestinal absorption of calcium, magnesium, and phosphates, and for a variety of additional biological effects. Low levels of vitamin D can increase the likelihood of developing multiple acute and chronic ailments, including cardiovascular and autoimmune diseases, diabetes, cancer, infectious diseases, dental caries, and periodontal diseases. In most people, more than 80% of vitamin D is formed in the skin after exposure to sunlight. Hypovitaminosis D status usually reflects deficient sunlight exposure, effectively dietary intake, or both. Recently, vitamin deficiency was linked with susceptibility to COVID-19 and severity of outcomes for patients with COVID-19. A few studies have presented conflicting results on the association between vitamin D deficiency and viral respiratory infection, partially because of the heterogeneity of the population studied and failure to adjust for comorbidities. Many respective studies have found an association between vitamin D level and COVID-19 severity and morbidity. Studies in the pediatric population demonstrated that patients with COVID-19 had significantly lower vitamin D levels compared with controls. In addition, fever was significantly higher in patients who had deficient vitamin D levels compared with patients who had sufficient levels. Additionally, older adults with vitamin D deficiency and COVID-19 had worse morbidity outcomes compared with those who were not vitamin D deficient. A prospective interventional study found that a high dose of calcifidiol reduced the need for intensive care stays in patients infected with COVID-19. A few studies have also reported on a significant association between sun exposure, vitamin D, and susceptibility to and recovery from COVID-19. Overall, significant controversies exist in the literature on the role of vitamin D deficiency in the prevention of and the treatment of COVID-19 and its treatment and its effects of severity of COVID-19. The present study investigated the patient registry of the large healthcare center, examining the strength of the association between vitamin D deficiency and COVID-19 after adjusting for likely covariates such as demographic characteristics and inflammation-associated comorbidities, materials, and methods. The study was exempted by the University of Florida Institutional Review Board as the study did not include personal health information. The UFI2B2 patient registry platform, which provides data aggregates from patients' visits from various UF healthcare centers, was used for the study. We searched the International Classification of Disease (ICD) diagnosis codes that occurred during the period of October 1, 2015 through June 30, 2020 for vitamin D deficiency, diabetes, and etc. The demographic data was provided by the platform. The odds ratio OR for the associations were calculated by logistic regression of the aggregates using SAS statistical software. The 95% confidence interval CI and p-value for each OR were tabulated. 0.5 was deemed significant. Power analysis was completed with the assumption that 24% of the population has vitamin D deficiency, with the incidence of COVID-19 at 0.4%, a total sample of 16,540 in the vitamin D deficiency group, 12,400 in the group with no vitamin D deficiency, achieved 80% power to detect a difference between the group COVID-19 incidence of 4 per thousand. The test statistic used in the two-sided t-test significance level of the at least 0.05%. Results for a total population of 900,000 patients, 800 were positively diagnosed with COVID-19. 31,000 were diagnosed of vitamin D deficiency and 87 patients had both vitamin D deficiency and COVID-19. This subgroup of 87 patients was composed of 89% adults, 71% males, and 88% black or other non-white individuals. Patients with vitamin D deficiency were 4.6 times more likely to have a positive COVID-19 status than patients with no deficiency. The association decreased slightly after adjusting for sex and malabsorption, respectively, for PA and DC, etc. Table 1 demographic information on patients with COVID-19, vitamin D deficiency, COVID-19 with vitamin D deficiency, and hospital patients. Vitamin D deficiency odds versus non-deficiencies, sex versus females. Confidence interval Bereshett's logistic regression models. In addition to adjusting for known risk factors for COVID-19 such as diabetes, obesity, and intestinal malabsorption, which poses a risk for vitamin deficiency, we have diagnosed for the presence of dental diseases DCPD and PA, which have recently been associated with COVID-19. The adjustments for dental diseases did not decrease the OR for COVID-19 dramatically, which supports the theory that dental disease and COVID-19 are both increased by vitamin D deficiency. As suggested by previous researchers, our data set included information on patients who were diagnosed with vitamin D deficiency over the period between October 1, 2015 and June 30, 2020, while the diagnosis of COVID-19 accuracy in 2020 using vitamin D levels obtained relatively recently, within the past 5 years, is the strength of this study. Research based on the 26 to 2010 UK Biobank data for vitamin D levels only weekly supported the link between vitamin D deficiency and COVID-19. Researchers have challenged the claim that vitamin D levels are stable over time, where the levels were assessed 10 to 13 years before the pandemic, rather than being stable. Mean 25 levels were shown to increase significantly over 5 years, and the increases was driven by overall increase in vitamin D intake in the most vitamin D deficient study participants. We can see that this study will end soon. This type of cross-sectional study cannot address the question of causality. Dental disease, vitamin D deficiency, and COVID-19 shared common confounding variables such as socioeconomic status and racial predisposition that may affect this association. It is noteworthy to mention that Black patients are disproportionately affected by COVID-19 dental diseases and vitamin D deficiency compared with other races, primarily because pigmentation reduces vitamin D production in the skin. Vitamin D triggers the production of the antimicrobial proteins, cathelicidins, and defensins that can inhibit viral replication rates and reduce levels of cytokines that generate the inflammation responsible for the damage to the lining of the lungs, leading to acute respiratory disease. Vitamin D also promotes the gene responsible for the expression of ACE2, which is down-regulated by severe acute respiratory syndrome, coronavirus. In addition to the well-documented effect of vitamin D on the immune system, a recent study has demonstrated that sunlight may rapidly inactivate SARS-CoV-2 on surfaces, suggesting that there may be an environmental benefit associated with vitamin D as a result of sun exposure, and the natural sunlight may be effective as a disinfectant for contaminated surface. This study may support the hypothesis that some of the protective effects of vitamin D against COVID-19 may actually be attributed to sun exposure, because vitamin D deficiency has been shown to potentially increase the risk of severe respiratory infections. Some investigators have suggested vitamin D supplements for prevention and treatment of COVID-19 complications, especially acute respiratory disease. However, the National Institutes of Health found insufficient evidence to recommend for or against using vitamin D supplementations, especially to prevent or treat COVID-19, and recommended to continue the previous established recommendations on vitamin D supplementation for other reasons, such as bone and muscular health, because people may require supplementation because of lower sun exposure during the pandemic. Nevertheless, recent systemic reviews and meta-analysis have concluded that vitamin D has potential to preventing respiratory infections, especially in those who have high levels of deficiency. In our cross-sectional retrospective study of patients registry, we did not have access to the individual medical information that seems to be of importance for observational study. Data on the initial infection severity status, the COVID-19 treatment, and the length of vitamin D deficiency are therefore missing. Nevertheless, the main comorbidities and demographic covariates were related and have been adjusted so that the strength of the association between vitamin D deficiency and COVID-19 could be established. In conclusion, the present study has demonstrated that vitamin D deficiency is strongly associated with COVID-19 deficiency, even after controlling for sex, malabsorption, dental diseases, race, diabetes, and obesity. Perhaps the most important finding was that vitamin D deficiency increased the risk of developing COVID-19 by a factor of 5 after adjusting for age. Prospective Interventional studies are required to validate the hypothesis that vitamin D supplements can be helpful for the prevention and treatment of COVID-19. Acknowledgement. We acknowledge the University of Florida Data Reservoir and the UF Health Office for providing the analytic data set for this project. Additionally, the research report in this publication was supported by the National Center for Advancing Translation Sciences of the National Institutes of Health under University of Florida Clinic Translation Science Awards. And these are the resources. Thank you for watching this video. I hope now you understand the benefit and the relationship between vitamin D deficiency and the COVID-19.